Dr. K. Bhujan Shetty sir, we gather today to celebrate a legacy that continues to inspire all. Good afternoon, ladies and gentlemen. A very warm welcome to Narayana Nethralaya Whitefield's first year annual day celebration. On stage for the lamp lighting,
दीपं ज्योति परब्रह्म दीपं ज्योति सरस्वती दीपेन हरते पापं संध्या दीपं नमोस्तुते दीपं ज्योति परब्रह्म दीपं ज्योति सरस्वती दीपेन हरते पापं संध्या दीपं नमोस्तुते दीपं ज्योति परब्रह्म दीपं ज्योति सरस्वती दीपेन हरते पापं संध्या दीपं नमोस्तुते.
Importantly, to open a new chapter in how we care about our children. Why a dedicated CVI clinic is required? CVI is one of the leading causes of childhood visual impairment. Here, unlike in traditional blindness, the eyes may be structurally normal, but the brain cannot perceive what the eye sees. So this is often underdiagnosed, which can impact on the development and learning ability of a child. What is CVI? So here there is impaired vision due to bilateral dysfunction of the optic radiations, cortex or both. Why do we see an increase in proportion of blindness due to CVI? Because due to modern medicine, due to improvement in natal care and all, there is increased survival of premature infants, leading on to increased incidence of CVI kids. Common causes of CVI, HIE, prematurity, periventricular leukomalacia, structural brain abnormalities and brain infections. I'll just give a short brief. So Dr. Gordon Dutton had compared, he has used the tree as a metaphor to explain that the roots as optic nerves and optic chiasm, trunk as the occipital cortex, and two streams, the dorsal and the ventral streams as the branches. First understand how visual processing happens. When do you suspect a child having CVI? When a child presents with a normal eye examination, but that does not explain the visual performance associated with any neurological problems or presence of any unique behavioral characteristics. So usually you see a child having poor visual attention, poor ability to maintain eye contact, and they have better response to moving objects, and they usually have difficulty in recognizing objects. CVI management goes beyond normal visual acuity testing. You need to have a functional assessment of vision. CVI clinic services will focus on providing a different functional vision assessment, refractive correction, visual stimulation. We have to include the parents as co-therapists to treat those children. After my talk, Mr. Nikhil will be elaborating all what we are doing in our CVI clinic. Collaboration is the cornerstone in active management of CVI kids. Team approach requiring like pediatric ophthalmologists, neurologists, pediatricians, and combined effort of therapists and other educators. Our vision with this clinic is we aim to give every child the best chance to see and interact with the world. Finally, I would like to thank the management and our team to make this clinic happen. Together, let us see beyond the eyes. Let us help every child see the world in their own unique way. I would like to conclude by saying, when we change the way a child sees the world, we fundamentally change the world they can live in. Thank you.
Good afternoon, everybody. Today we are looking into the vision therapy in neurodivergent cases. I know many therapists are sitting here. So many of them have thought vision therapy means just an eye-hand coordination, eye movement exercises. We'll see what is the role of vision in the developmental and behavioral aspects, learning aspects. Vision is more than 20/20. 20/20 or 6/6 is just the quantity of the vision what we are seeing. As per the behavioral and developmental optometry, vision is something like making sense of what you see. The meaning of that is like making sense of what you see. So I'll be elaborating on it. Tiffenthal was the father of behavioral optometry. He said vision is an emergent. So it emerges with these four circles. So one is center, identification, anti-gravity, and speech and auditory. Later on we saw with the neurological thing. So neurologists also said it's the same. Neuroscience also said it's the same. Centering is something like where is it? Identification is something like what is it? And anti-gravity is something like where am I in the space? Speech and auditory is something like what do I do? to have this. So this is an effect of a dorsal stream and this is an effect of the ventral stream. Let's start with the story. Let's say there are so many people sitting here, there are so many objects, there's an apple at some corner. So if somebody asks me, can you get me the apple? Though I don't see it consciously, before that I'll come to the visual science. In the visual science we have got two kinds of vision, one is central vision, the other one is peripheral vision. Central vision is a component of a dorsal stream which is considered as a conscious vision. Peripheral vision is a component of dorsal stream which is considered as subconscious vision. Should I repeat it again? Central vision is a component of ventral stream, peripheral vision is a component of dorsal stream. So conscious and subconscious vision. Going back to the apple, though there is an apple somewhere in the corner, though I don't see it consciously, somewhere in my subconscious vision, the brain knows that there is an apple in some corner. When somebody asks me for an apple, so it just shifts from center to the identification, goes to the ventral stream, checks the forms of the apple, varying the color of the apple and the shape of the apple. It goes back and checks with my visual memory whether it is still the same or anything else. And then it will shift towards the centering, which is again a dorsal stream which will navigate me towards the apple. So vision is an input, the ultimate output is a motor action or speech or auditory, something like that. So anti-gravity, third circle, we are all against the gravity. So for this, three systems are working together as a team. So one is vision, the other one is vestibular, the other one is proprioceptive. If one of this gets collapsed, we'll be misbalanced or we'll be feeling dizzy. There are so many syndromes like visual vertigo syndromes. People, they go to ENT specialists, the vestibular is fine, and once we see the performance with the eye, then there is a lag between the vision and vestibular inputs. So we treat it like that. So in the form of vision, if you want to say, so we have two eyes. The brain captures both the images from both the eye. It will mark one point as a center, which is the midline of the eye, and that is considered as a visual ego center. So we can tell it as a visual centering also. Depending on this ego center, the brain puts the weight on both the sides of the body to hold straight. Or else if it is putting abruptly on each of other sides, will lean on one side. So let's say the visual ego center is shifted or it is absent. So the brain puts more on towards the left, will lean more towards the right. If it is putting on the right, will lean more towards the right. So that important is the vision. The second vestibular also, it checks where is the gravitational pull. Is it in line with my body, or it is anterior to my body or posterior to my body? So that if it is anterior, it knows that the body is not in the lane, and it will check the proprioception also. Why I am telling this is, the further talk, this is all important. Okay, in the proprioception, it checks the neck muscle. It will see where is the head in the space. Is it anteriorly tilted or posteriorly tilted back? It checks. Taking on all this concept, it will align the weight on both the sides of the body. Speech and auditory, going back to the first example, somebody asked me for an apple, that is why I looked for the apple, went and bought the apple, gave it to the concerned person. That's a track where I started with. Auditory impulse, I responded to it and I did a motor actions with the help of my vision. Speech, if somebody asked me that whether is there an apple in the space, I would say yes, no. Again, vision is important. So it is said that 70% of the brain development happens because of the eye. Because how we see is how we learn and how we respond. So that important is the vision. Why I chose this to us when I was out to invite specialists here. Multiple specialists asked me a few questions. So I've put all the questions here in the slide today. Decreased eye contact. This is the main concern of the parents and the therapists. There are therapists who have sent to me, the speech therapists, obviously they have sent to me saying that the child is not able to follow the lip movement which I am trying to do. They are saying that if the child sees, only then I can teach him something. Why this is this? The face itself is a complex thing. Because as we are talking, we are blinking, we are moving our face, we are moving our lips, and we are expressing. We are changing the expression for each time. So this thing, for this neurodivergent case, it's very difficult to look. Face is a complex thing. The second point, the child can't integrate the center and the periphery, or the child cannot integrate the vision and the auditory. So because of which, if you are talking to the child and you are expecting the child to see, he will not be able to comprehend what you are trying to say. If at all, if the child is looking somewhere off the axis and trying to listen, he is listening because he wants to respond to you. So you are expecting him to look and then talk back, he will not be able to do it. We are able to integrate auditory, visual, proprioceptive, tactile, everything at the same point, same time. But those kids are not like that. Dr. Robert said that these kids are disconnected kids. Means the right and left hemisphere are not working, likewise it is working for us. They work as a separate When sometimes they are like right dominant, sometimes they are left dominant. I'll come back to it. Visual version, we have two eyes, but if they are not coordinating well, they'll see as two. They'll see as double. When there's a double, there is too much of confusion for the brain. There's too much of noise for the brain. To avoid that, what they do is they tend to look like this. So they can shut one of their visual impulses and they can look with other one. Corner gazing is also same thing. They can't integrate the central and periphery vision, that because of which they want to shut down the center vision and they want to look with the peripheral vision. It takes a lot for them to see from the center. It's kind of draining their energy. When there's a draining of energy, it's very difficult for them to survive. This is all the survival skills they which learn actually. And hyperfixating on the object, that's the same thing actually. They are not able to integrate on central and periphery. Toe walking. As I said, for the balancing, three things are important. In the toe walking, what happens is your vision and vestibular is not giving a proper input. Because of which the child tends to do this. By doing that, there is a stress there is a tension on the calf muscle and the ankle muscle, which gives a very high inputs for the brain, saying that how is he standing on the floor. If it is like this, he'll roll faster. If it is like this, he'll roll slower. If it is flat, he'll walk in the normal pace. So that's why for that impulse to get, he'll do a toe walking. We have our various way to correct it. What we do is, I was showing, I can show it again. We'll use yoke prisms so that we'll shift the floor like this, so that once the floor is shifted, the gravitational pull is from the behind. When there is a gravitational pull is from the behind, the weight shifts on the ankle. The weight is also shifted towards the gravity and he'll land up like this. So if he's doing toe walking, to make him land, we use this technique. Light sensitivity is something like, these kids, as I said, they are not able to integrate with the other senses. What happens is, they are always on the stress. When there is a stress, there is sympathetic nervous system which is in superactive mode. When there is a sympathetic nervous system which is superactive mode, it will not let the eye pupil dilate and constrict. So when the pupils are dilated, there is an enormous amount of light which is entering their eye. Because of which they tend to avoid light. They'll run out of the illuminated room, fully illuminated room. If they are out of the stress, the pupils can constrict and they can avoid the light. So that's the reason for an intense light sensitivity. Preferential looking at the object, again they are not able to differentiate between the center and the periphery field. We have right brain working for seeing as a whole. When it's like a room, if you are seeing a room, you will be seeing as a room as a whole or as a part. Whatever the job we have to do, first what we do is we'll see as a whole. If that makes sense to the brain, only it will perform, or else it will look as a part. If that makes sense to the brain, then that will perform. So in this case, they are usually right brain dominated. So they will try to look as a whole, they don't try to look as a part. So we will teach them. The whole and the part is again the peripheral vision and the central vision. Kids who are left brain dominated, they are superb at the math. So there was one kid who came to me and he was very focused in the center. You tell him your date of birth, he'll tell you which day you are born. If you tell that I am born on this date, he'll tell you immediately, within 2 seconds he'll tell you. You can't even imagine, you can't even do that levels of math. So if the child is left oriented, left brain dominant, they'll do like this. If they are right brain dominant, they'll see everything as a whole. They don't look as a part. We have to teach them how to look as a part. Anxiety or avoiding the moving object is the other thing, because for them, usually this we see in the CVI kids. If something that is moving, they can't track. It is like a picture coming here, escaped here, coming back here, escaped here, coming back here. There is a break in the image, there is no continuity, because of which this child gets frustrated because there is a glimpse of images. Flickering the finger, this is the second major concern which I have heard from the parents and the therapists. They do this hand flapping, they do this all things because they want to avoid the periphery vision. When your fingers are brought close to your eye, there's an obstruction of the peripheral vision and they are more focused on the center. That's the thing. Abnormal body posture, again, if your peripheral vision is not good, you will have an abnormal body posture. Signs, as I said, integrating vision and the other senses, it's not possible in them. Poor fixating, refractive error. This is a first concern of mine. No matter how much ever the child has gone to the hospitals, we start with a power checkup. Because there was a kid who came to me saying that, parent came to me saying that he is diagnosed with the autistic and we need therapy for it. So when I saw him, I found -10 power. So -10 is something like you can't see things beyond 20 centimeter. How can you expect the child to go freely? The parent complained that he is very dependent, so if you leave him in a room, he'll become cranky. Yes, ma'am. If the child is not able to see beyond 20 centimeters, he will feel afraid. He will feel threatened. He don't know what is the obstacle coming in front. So he will feel. And when he came to me, he was having the slogan "Mane Bogana, Mane Bogana, Mane Bogana." When I put -10 power, he kept quiet for some time. He looked around and he stopped. And then we prescribed the glasses. After 4 weeks, I called for the visit, and he came alone. He didn't come with a parent. He came alone inside. That was a story behind this refractive error. We always start with the refractive error, no matter whichever the hospital they have ran to. Poor balance and coordination. That's again the periphery and the central vision. Assessment, visual acuity assessment. As I said, the power checkup first, and we'll see in the second oculomotility how well they can move their eye in the all directions. Non-strabismic binocular vision. It's like 22 types of tests which we do to check whether the focusing muscle and the coordinating muscle are working together. Developmental visual information processing. This test we have around 25 to 30 tests. Altogether we have around 50 tests to conduct, which we don't do it in the first go. This is something like how brain is relying on the vision. Developmental visual information test we do it because to check how brain is relying on the vision. Alpha omega pupil, I was telling when this child is on stress, the sympathetic nervous system is super active. It will not constrict or dilate. We are going to check, there's a method for that. We are going to check how well the pupil can constrict, how pupils can dilate, and what second gap it will take, so that we can work on it. So if the sympathetic nervous system is super active, we know how to neutralize it. We have a therapy called Centonics, or light vision therapy. Primitive reflex, yes, we give importance for the primitive reflex also, because we feel that without primitive reflex, whatever we are doing, it's like building a building on the weak foundation. No matter how much of a therapy I do, it will collapse one day. This is how we do. If the child is not responding, we use that. We use this black and white high contrast one. The other one is something like plain. The child will look towards the high contrast. It's called preferential looking test. Leah patterns, and this is the power checkup, and this is we are checking how well the eye can move, and this is something called a photorefractometer. So if the child is not cooperating for a retinoscopy, which takes a good time, the instrument gives the power within 3 seconds if the child is looking. So just within 3 seconds it will give the power. Not be appropriate, but it will give a stepping stone so that we can how much to prescribe it will let us know. This is an ocular motility test and non-strabismic binocular vision disorder. Visual perceptual skills. This is a test for visual perceptual skills. From the perspective of the vision, we need around 7 perceptual skills to learn things, whatever it's new, old, whatever it is. So this test is used from the age of 5 and to 21. This has around 180 test plates, but we can't perform it at a time, so we'll do it little by little. And the first one is visual discrimination. Visual discrimination is a basic skill which you need to learn. When you can discriminate between a square and a triangle, we can teach you anything. If the child comes to us with very poor discrimination skills, we start with very small. This is a very high standard which I am trying to show you. We actually start with a very small one. The second one is visual memory. So let's say your footwears. How do you understand that's your footwear when it is part of the crowded space? You have little of picture of it. You have choose something which is little different in a pattern which you have recognized through your vision. You know that my slippers, my footwears are in this color, this shape, this size, and that is when you recognize it and you again rewear it, or else you wear someone else. Visual spatial relationship, you have to know, if you want to point out something in the space, you have to know right and left of your body. Only then you can say. For example, so I can say that the projector is to my right, the window is to my left, because I know which is right and left. The kids doesn't know right and left. That is when they can't communicate with you saying that where is what. So first we'll teach which is right and left, because my right and left and your right and left are not the same. My right is your left is my right. So we will teach our own bodies right and left, and then we'll teach the opposite side, which will help them in communicating, learning and exploring things. Visual figure grounding, so many people ask us that, sir, he is not able to pick from crowded environment, he is not able to pick, do that, this. Why? Because I am telling you, if the right brain is working, if the right brain is dominating, they'll see as a whole. They don't know how to see as a part. We have to teach them how to see as a part also. Visual form constancy, parents usually does that. They'll show a bottle, tell the color of it, size of it, and they'll say this is the water bottle which you have to sip. The child thinks that anything in that size, anything in that color only is a bottle. So if you show something like the child is using half liter bottle and you bring 1 liter bottle, the child doesn't understand that's a water bottle. Visual figure closer. This is again the images are halfway completed. The child can't recognize it. So if it is full way completed, it can recognize. Visual sequential memory is also something like that. We do it in high functioning CVIs, high functioning autistic cases. When the child has gone for the school, there is written VISION. So he is just copying one by word. VIS. He doesn't know how to copy it as a whole or sequentially memorize it. DVIP, we are running out of time. I'll just pass on with this. DVIP is something like developmental visual information processing test. We check bilaterality, how both the sides of the body can move together or simultaneously. Visual spatial skill, we have Piaget, right and left concepts. Analyzation skills are like TVPS, as I said. Visual motor, BDVMI, like visual guided motor movements. Auditory visual integration, both are important. Auditory and visual both are important. So management, we manage in the developmental fashion. We start with the primitive reflex, then go to balance and vestibular. If the child is on primitive reflex, we just directly jump to balance and vestibular, then the ocular, then the cognition. The visual perception skills comes at last. And now there's a new trend of therapies. They are lasering the powerhouse of the cell. Where after doing so many of therapies, also if the child is not developing that energy, they are lasering that. It's called low light laser therapies, and also it is called as photobiomodulation therapies. They are lasering 58 parts of the Brodmann's area when it's connected to the Brodmann's area. Again, primitive reflex is the first behavioral lens prescription. We might prescribe spectacles in the form of prisms or tinted lenses, ocular motility therapy, eye movement therapy, visual stimulation, it's for CVI, and therapy for eye-hand coordination, eye teaming, getting their binocular vision, visual perception skills. Yes, we give importance for the nutrition also. Why? Because we believe that if the nutritional levels are not high, the brain development will not happen. And we give importance for the casein-free and gluten-free things also. The goal of the therapy is to improve the child's quality of life and overall well-being. I think the goal is same for all therapists here. Thank you. Thanks for patience listening.
Good afternoon to all of you present here. Today marks a very special milestone for us as we inaugurate the Ocular Prosthetic Clinic, which is also known as the Artificial Eye Clinic. This is not just the beginning of a new facility, it is the beginning of renewed confidence, restored identity, and quiet healing for many of our patients. The loss of an eye is not merely a physical loss. It carries emotional, psychological, and social challenges. Through this clinic, we aim to address not only the cosmetic rehabilitation of our patients, but also their self-esteem and overall quality of life. With advances in oculoplasty and custom eye prosthesis fabrication, we are now able to provide highly individualized, natural-looking artificial eye that helps patients return to their daily lives as soon as possible with confidence. Our goal is to ensure that we provide a compassionate and comprehensive care, and I would like to sincerely thank the administration and everyone involved in making this vision a reality. Confident that this clinic will help serve our patients and provide one of the best ocular rehabilitation. Let us move forward with dedication, empathy, and a commitment to restoring not just appearance but hope. With this, I would like to invite Ms. Anushri, our in-house ocularist, to walk us through the art of making an ocular prosthesis. Thank you.
Good afternoon everyone, this is Anushri. Let's get started with the art of ocular prosthesis. So what is ocularistry? It is nothing but the science of making ocular prosthesis. Ocular prosthesis is just an artificial eye which replaces the missing or the damaged eye, which helps to restore the confidence and the appearance of the one who have lost their eyes due to diseases, inflammation or severe injuries. It also protects the eye socket from infections. So the types of ocular prosthesis, the customized ocular prosthesis, these are made up of high quality acrylic material. These are customized to fit the individual's eye socket, and these are hand painted to match the color of the companion eyes. It provides the good optimal cosmesis with excellent symmetry. Then the next one is a ready-made artificial eye or the stock shells. These are prefabricated, available in all standard size and shapes. Scleral shells, these are iris painted scleral shells. These are very thinner in size. less than 1.5 mm when we compare to the COP or the ready artificial eyes. Fourth one is a symblepharon rings, which are designed to create the adhesion between the eyelids to the eyeball or to the conjunctiva. These are pressure conformers we usually use in cases of microphthalmos to increase the size of the congested socket, which is known as serial socket expansion. Then these are the clear acrylic conformers these are fitted after the surgery to hold the shape of the socket. When do we consider ocular prosthesis? Post-surgical removal of the eyeball, enucleation, evisceration and excenteration. And in cases of microphthalmos, it is a developmental disorder of the eyeball which abnormally smaller in size than the cysts bulbi. These are usually caused by inflammation or severe injuries. The next one is anophthalmia. This is the difference between the stock shell and the COP. In the first picture, patient is wearing a stock shell in his left eye. You can see this is a cysts bulbi. So he was not ready for the COP, so we have inserted a stock shell. So as you can see, there is a difference between the color when we compare to the companion eye. The size and the shapes also there is a difference. So the second image shows the hand painted artificial eyes, which are nothing but customized ocular prosthesis. The size and the shape and the color is masked according to the patient's left eye. You might have all wondered how we make the artificial eyes. So first we'll be taking an impression, then followed by wax modeling, then we'll be doing a casting, finishing and polishing, painting and detailing, clear coating, then final fitting and polishing and the final inspection. This is the video how we prepare an artificial eyes. Now currently I am taking an impression. I am mixing the alginate paste, now is injected to the socket. I am preparing an alginate cake there. That impression tray is placed inside the alginate cakes. Now I will be pouring a wax. So once the wax is poured, once it is hardened, we will be trimming and polishing by using a gas burner. Once it is inserted inside the patient's eye socket, we will be marking the cornea according to the patient's companion eye. So now it is a casting. I will be keeping those wax mold inside the gypsum. Now I will be creating the PMMA white, which is nothing but the scleral base. So once the scleral base is ready, we will be keeping this scleral base inside for the polymerization. So approximately for 180 degree for 45 minutes we'll do a polymerization. So once the painting everything is done, we'll be doing a clear coating. So again the polishing and trimming has been done there. To meet the good prosthetic fitting, one has to have adequate fornices in all quadrants, the normal tear secretion, adequate orbital fat, well centered and covered orbital implant and absence of inflammation. How do we care and maintain this cosmetic eyes? It is recommended to clean the prosthesis with a mild soap and water. So patients have to remove their shells every 15 days once to clean it with normal water, and they have to use a soft cloth to wipe the prosthesis and the eye socket. Avoid harsh chemicals and abrasive material because there is a chances of getting the paint might fade. That's why they should avoid harsh chemicals, and the regular polishing and to maintain the shine. When do they have to come and meet the ocularist? So under 3 years old kids, every 3 months once they have to come, as kids are growing in age. So there might be changes in the eyes, the artificial eyes. If there is any modification is required, so we will be doing a modification with the same shell. Under 9 years, twice a yearly. Other patients at least once in a year to clean and polish the prosthetic eye. The life of this prosthesis will last between 5 to 7 years if they have maintained well. Thank you.
Now we proceed to the lunch, and anything we'll discuss in the lunch. Thank you all for coming.
Yes, smile everyone. Coming. Hagari. Smile.
but they have sent the photo to the class.
Hello everyone, I'm Dr. Narayana Shetty, Director of Narayana Nethralaya. Today we are inaugurating the CVI clinic at Narayana Nethralaya Whitefield branch. Now CVI clinic is a very unique clinic. Not many centers in the world in fact have, in ophthalmic hospitals have CVI clinic in it. So what is this CVI clinic? CVI, the meaning of it is Cervical Visual Impairment Clinic. So here when we look at the children, the eye is perfectly normal. There's no problem at all, but the child cannot see. Now why is that? Is because of the brain problem. And in this clinic, we take these children, first we assess how much vision are they using, how are they using it. In different other things also we do assess. We see their motor skills, how their hand-eye coordination is, and also how is their communication skills, behavior skills. So all of this will be assessed, and once it is assessed, we do a very customized program for them in different ways where we can stimulate the vision in terms of bright colors, lights, bright toys, and we have a specialized software, which is in fact most of the equipment is got from abroad. It's not even available in India because we wanted the best devices and the softwares for these children. Once we do the visual stimulus, we do other sensory stimulus also. We do the hearing stimulus, we do the touch stimulus, and this way we do a multidisciplinary approach wherein we also use physiotherapy, which is the other therapist also we use is occupational therapy, speech therapies. So all of them we use them, help the child to be more independent, and we shift these children from a special school to a normal school. So we have treated over 1,80,000 children now, and almost 20,000 children we have shifted from a special clinic to a normal school. So by doing all of this, we enable the children to shift from a special school to a normal school. So that is the beauty of it, and I'm very excited that we have come to Whitefield closer to, because we have been getting a lot of requests from a lot of patients. Please come closer. As you know, in Bangalore we cannot travel anymore. That is why we are coming closer to you. I hope this will help more and more children, and please kindly spread the word. Thank you so much.
Hello, I'm Dr. Harsha Nagaraj, Medical Superintendent of Narayana Nethralaya Whitefield branch. On the occasion of our first anniversary of Narayana Nethralaya Whitefield branch, we are opening two services. One is what we call the binocular vision therapy and the cortical visual impairment treatment department, as well as the ocularist lab. In the binocular vision therapy, what we are doing is we are helping out those professionals who work excessively on computer usage and have symptoms related to dry eyes, strain and all those. We evaluate their eye muscles and see if there are any symptoms due to their muscle spasm, and teach them exercises where they get relief. In the cortical visual impairment therapy department, we treat those kids and adults who have vision problem due to either their neurological problems such as autism, or maybe due to cerebral palsy, etc., where they can be given multiple sessions and treatment to improve their visual acuity. The other department is the ocularist lab, where people whose eyes have been removed due to multiple reasons like either infections or malignancy or something, where we're going to provide them with artificial eye prosthesis which will make them look better cosmetically. Thank you.